Okay, so let's carry on with diabetes. So like I said, 50% of these, unless they make lifestyle changes, they will develop type 2 within 5 years. So the normal range of blood sugar in pregnancy should be 70 to 110. So there are complications with gestational diabetes for the mom and for the fetus. So the maternal complications can lead to a spontaneous abortion or a miscarriage. The risk of premature rupture of membrane, so when the amniotic fluid sac ruptures prior to the onset of true labor. Preterm labor, where she's contracting before 37 weeks gestation, and also hemorrhaging. So preeclampsia and eclampsia is strongly associated with gestational diabetes. And because these babies have lots of sugars on board, they grow to be larger than gestational, large for gestational age. That's what this LGA stands for. And so they're not able to give birth vaginally because the shoulders are so big and they would get stuck in the vaginal canal. So they have to be delivered via C-section a lot of times. And then she has risk of vaginitis or UTIs due to the favorable bacterial growth environment. So she's at high risk for more of those than usual pregnant women. So for fetal complications, you see right here, taking a blood draw, they're going to have lots of instabilities when they are born. So they're going to be born large for gestational age, which is a weight over 4,000 grams. And they have increased glucose, leading to increased fat deposition. So these are big babies, bigger than they would be normally for their gestational age. And like I said, they are at high risk for shoulder dystocia. Shoulder dystocia is when the head can come out, but the shoulders get stuck during labor, and this is a obstetrical emergency. And then hypoglycemia. So what happens is they have these high levels of sugars on board, and so their insulin levels are high in utero. And then when you cut that cord, you cut off their sugar, and so they still have these high levels of insulin, so they blow through their sugars pretty rapidly. So what happens with these babies is they become hypoglycemic fairly quickly, and then they have sugar instabilities for a while. So they go to the NICU, and we're giving them IV sugars, and we are monitoring that sugar, their blood sugar, pretty regularly, pretty closely. And then, so how we deliver the gestational diabetes diagnostic takes two different tests. So we're going to monitor, this is back to the mom now, so we're going to monitor the glucose between 24 to 28 weeks. So during their prenatal exam, we're going to give every pregnant woman this 1 hour glucose challenge test. It's non-fasting, and we're just going to see what happens. If it's a positive result, meaning anywhere above that 110, so 130 to 140, they will have to have another test right here. So this is the second test, and this time it's a 3 hour glucose, meaning you have to monitor their glucoses in 3 different hours. So this one is a fasting. They have to come fasting this time, and we take their sugars at 1, 2, and 3 hours. And if their sugars are still high for these three different time periods, then they get the diagnosis of gestational diabetes. So how do we treat gestational diabetes? Most of the time, 70-85% of the time, gestational diabetes can be controlled with nutrition, exercise, and just monitoring that glucose pretty regularly. If that fails, then we can order insulin. It's very rare, and we can use glyburide or metformin. Both of those have been okay to use in pregnancy, have the least amount of harm to the fetus, the growing fetus. Okay, so the next thing we're going to talk about is hypertensive disorders. And these are not only high blood pressure in pregnancy, but also preeclampsia and eclampsia and HELLP syndrome, those types of things. I have this video right here. I will post it. This is under osmosis preeclampsia, and I'll put it underneath this video. And I also have another video that I posted by Khan Academy. It is for medical students, so that one's a little bit more involved, and maybe it's more information that you like to know about preeclampsia. The osmosis is really good, short, sweet, and to the point, and gives you a really good overview of what preeclampsia truly is. The Khan Academy one is really informative, but I'm not sure it's for everybody if you're not really interested in this realm of nursing. Anyway, both those will be there for you. So preeclampsia. So women can have high blood pressure, but it's not preeclampsia. So normally remember that the blood pressure should decrease because of the vasodilation throughout her vascular system. If you see an increase in blood pressure with no other signs and symptoms, then that's just maternal hypertension, and that could be something that she had a problem with before she got pregnant. She just didn't go in and have it checked or monitored. But if you see increased blood pressure, and it doesn't necessarily have to be above normal, it just has to be above her baseline. If you see that happening after the 20th week, especially if it's associated with these different kinds of symptoms, then we're going to diagnose our patient with preeclampsia. So if you watch this video, you will see that preeclampsia is caused because of the placenta does not attach normally to the uterine wall. And what happens is these spiral arteries, which are branches off those large uterine arteries, instead of becoming dilated and wide and allow for lots of nutrient exchange, blood to flow from the maternal bloodstream, they become constricted, and that leads to not enough oxygen getting to the placenta. So the placenta acts, it's angry, kind of, and what happens if the tissues don't get enough oxygen in our bodies, and this happens with the placenta, they send out inflammatory factors. Sometimes they're called proteins, sometimes they're called factors, and those attack the endothelial layer of the entire maternal vascular system. So you'll see lots of different problems associated with the damage to her blood vessels. So it is the most common medical problem in pregnant women. It is the highest cause for preterm delivery as well, because how you solve this problem is you deliver the baby and you get rid of the placenta. That's the only way to stop preeclampsia. And when there's severe problems and emergency situations, they will deliver that baby even at really young ages to save that mom's life. So it's associated with a lot of really scary things: placental abruption, kidney failure, liver rupture, preterm birth, and then it can even lead to fetal maternal death if you don't get that baby out. It begins, and remember I said it was high blood pressure beginning after the 20th week. And the risk factors for this, see right here, this African American, you see tons of babies in the South just due to preeclampsia. There are just tons and tons of NICUs filled with babies, and they are there because their mom had preeclampsia. But there's other risk factors for it. A high pre-pregnancy BMI, having more than one, so twins, renal disease, family history. Remember those risk categories: less than 19 or older than 40. And then it can involve lots of different organ systems, not just the blood pressure. It can cause lots of damage for baby and for mom. So we're going to rate the preeclampsia, and when you're working on your case study, or not your case study, sorry, your concept map, you will look on page 60, And I would include everything from page 60 and page 61 because that talks more about just how we diagnose it, but also the treatment, especially magnesium sulfate. Magnesium sulfate is a big subject on labor and delivery nursing in your ATI and or NCLEX. So really learn preeclampsia and include magnesium sulfate and how we test for toxicity and what the antidote for magnesium is. Okay, so anytime there's a blood pressure that is greater than 140 systolic, 90 diastolic, we're going to get that on 2 different occasions, and they must be taken at least 4 hours apart to make sure it's just not a misreading. And or if they have low blood pressure starting, if you see this sharp increase in systolic or diastolic blood pressures, then we know that that's still going to be categorized as mild preeclampsia. That's why those baselines taken in the prenatal appointments are so important. You're going to see slight proteinuria, 1+ or greater. This is just a way to categorize it. And then you might see a mild transient headache caused by constriction and problems in the blood vessels in the brain. And then they can continue on to having severe preeclampsia. So severe preeclampsia is still diagnosed with clinical manifestations. So all these different kinds of things. You're going to see a blood pressure, typically 160 over 100, proteinuria greater than what you saw with mild, extensive peripheral edema because you've got these leaky blood vessels and they are just leaking out albumin all over the place. They're going to have, they're dehydrated because all of their, volume is going into their interstitial tissues. You'll see headache and blurred vision, hyperreflexia, so they have these hyperreflexes, and then possible ankle clonus. You can click on this YouTube video and watch. Ankle clonus is where you push the ankle down and it kind of comes up in this pattern, this rhythmic pattern where it bobs up and down. You can watch that if you like. And then also we're going to see liver dysfunction. That's where you get the epigastric and right upper quadrant pain, which is a classic hallmark sign of preeclampsia, and you get that from the stretching and the inflammation of the liver capsule. So associated with severe preeclampsia is what's called HELLP syndrome, and I want to make sure you understand the difference between HELLP and preeclampsia. So HELLP syndrome is still severe preeclampsia. It's just a different way to diagnose it. And we diagnose HELLP syndrome with lab findings, not clinically like preeclampsia. So preeclampsia, we're going to take an assessment, we're going to do an evaluation of the patient and take a history and learn some things to diagnose preeclampsia. With HELLP syndrome, they're going to come in and they're going to take these labs. And if you see all these certain labs come back abnormal, then we're going to diagnose them with HELLP. When a woman is in HELLP syndrome, or she's experiencing HELLP syndrome, that's an emergency. You have to take that baby out right away, or it could lead to massive permanent organ injury, DIC, and possible death. So what is HELLP? It's 3 different labs. So H is hemolysis. You're going to see a low hematocrit not explained by blood loss, and that is due to the body trying to repair those leaky blood vessels. So they're going to start putting plaque in there to repair those blood vessels, and as the red blood vessels kind of come by, they're going to be destroyed by these blood vessels. It shows you in that osmosis video pretty well, a really good sort of animation of that happening. And then the next one is elevated liver enzymes, and that's what's leading to the epigastric pain and nausea and vomiting. So it's elevated, it's inflammation of the liver that's causing this. And then low platelets, same thing caused by this. It's the destruction of her blood vessels that are causing both of these. So we know low blood platelets, you're going to have abnormal bleeding, abnormal clotting times. So you're going to see things like bleeding gums and petechia, however you pronounce that. And those three things, if you see those, you usually see those come in through the ER, and you know that that woman, it's a medical emergency. Okay, I'm almost done, so I need to pause and start again.